Hello, everyone. We're going to give this a minute to make sure everybody can join us. I'm so happy if you're here. So we're going to be talking about IIH, and POTS. But let me make sure that everybody's on who can be on, and that you can hear me okay. Feel free to leave something in the chat if you need to send me a message. I'm going to rearrange things on my desktop. I think we got it. Awesome. I am so happy to talk about this. The Patreon Rebels, and thank you for your support in that, have asked me to talk about is POTS and IIH related? IIH, idiopathic intracranial hypertension, oftentimes without papilledema, in which case we call it IWAP. Are those two conditions related? And the answer is oh, yes, they are. And it is so easy to miss, but it is just life-changing to recognize it and to be able to get on top of it. So we're going to chat a little bit about that today, and I will be opening up some education to dive very deeply into that. I think that subject is that important. So first, those of you who have looked at the Driscoll Theory book, and although this book came out in 2012, it is still 15 years ahead of anyone in POTS research, which is amazing to me. But the first thing that was released in that book was a propensity to develop intracranial hypertension in POTS. And although it isn't everyone, it's a majority. I would say it's between 80, 85%, maybe more of the patients we see at POTS care. Now, some patients we've seen too didn't exhibit it when we saw them, but it showed up later. So it's a very important topic, and we don't present as typical. So you want to be able to recognize this if this is happening. The symptoms of idiopathic intracranial hypertension can be POTSy symptoms, if you will, like dizziness. There can be some different difficulty in breathing, shortness of breath, having difficulty getting a full breath. Insomnia is a big clue. And then we tend to get pain or discomfort at the base of our skull, the bottom of the head here, top of the neck, and then the muscles tighten below it, and our necks tend to get real stiff. So turning our head right or left, it can feel stiff. And I used to think I had a pillow problem, that it was something with the pillows. It doesn't feel when you're a patient like it has something to do with intracranial pressure. That is just not where we go mentally thinking about it. But if your neck is stiff, think first IIH. And then I felt oftentimes like my brain was suffocating. This is, well, it can't make you sound like you're a crazy person. I felt like I cannot get any oxygen to my brain. And I would check a pulse oxygen level and it was fine. And I was breathing. Oxygen was going in and out, although sometimes it was difficult. But I felt like my brain was suffocating. And I look back now and understand that the intracranial pressure on the brain squeezes things. Basically, there's only so much room in the skull, so something's got to go. And the first thing to go is the circulation. So we really are not getting the oxygen perfusion in the brain that we need. Now, when the fluid collects in certain areas around the brain, like the top, for example, it can tend to push things down, but it can also collect at the base of the skull in a little cistern there. And when it collects there, it can put pressure right on the brainstem. And the brainstem is your autonomic nervous system center. So we can get some really weird and dramatic changes. I remember if I laid in bed on one side, my heart rate and blood pressure would do one thing. But if I rolled over and laid on the other side, it was completely different. And I remember thinking, the doctors are never going to believe this, right? What the heck? And then once I recognized when I leaned forward, my heart rate would go up. And fairly significantly. I showed this to my neurologist. I said, something is wrong here. And he said, Well, it could just be that you're doing a Valsalva. You're holding your breath, you're pushing. Went, okay, I'm sure that's what it is, right? I really wanted that to be it. But I did it again, just totally relaxed, and had my family do it too. And that was not it. That was not what was happening. But it was putting pressure on the brainstem. And I do remember a Chiari surgeon telling me once, even a feather's touch on the brainstem causes significant symptoms. And I did not have Chiari. There was no Chiari whatsoever, but I had symptoms of Chiari. And most of us with IIH develop those. So keep those in mind. In the clinic, anytime we have a patient who faints fairly easily, we almost always know they probably have IIH, or at least we certainly can't not check for that. Okay, especially patients who faint repeatedly and very easily. Those are almost always IIH patients. And then we also tend to get, as patients, we get what I call episodes, for lack of any other word for this, where we get a wave of symptoms. We usually feel hot, our hearts race, we feel kind of panicky, and oftentimes it'll wake us up from a sleep, almost like someone jolted us awake. And it feels like your body is being destroyed. It is something that will send a full-grown man to the ER. I know it sent me to the ER a couple of times. Patients who have a lot of episodes, especially when they occur at nighttime, tend to have IIH. So IIH mimics many other conditions. One, migraine. I belong to a headache society, and they have a journal, and I look through the journal at all these articles about migraine and resistance to treatment, et cetera. And I think, have a feeling a lot of those people are similar to our patients, where they're often diagnosed as migraine, and it's not migraine, it's IIH, and responds fairly quickly to treatment. It can also mimic CCI, or craniocervical instability. I felt that way. In fact, I had a friend going through this at the same time, and he and I would tease because we got these bobblehead toys and go, yep, that's us. That's what it feels like. It feels like you're real unstable. And then when you turn your head, it feels so tight. A couple times I turned my head and it felt like I was going to pass out, like my brain and my body disassociated for a minute, which again, I don't even know how to describe that. But those were all symptoms of craniocervical instability, but it wasn't craniocervical instability. Those were IIH and responded fairly quickly to treatment. It's also very similar presentation to spinal leaks. And I think this warrants a discussion because there is so much press out there about spinal leaks in POTS and similar conditions. And we find at the clinic that this is way overdiagnosed, that almost always the patient is actually displaying high intracranial pressure. The symptoms of a leak and the symptoms of high pressure are almost the same, but leak patients, when they sit up, they tend to have fairly dramatic headaches, that when they lie down, they're better. But I think what's being said out there is that, well, when there's slow leaks, you might not get that same headache. Those patients would do themselves a service to first consider the possibility of high intracranial pressure. And it is finally being recognized that most leak patients have underlying high pressure, and the fluid pressure builds and it looks for a place to go, if you will. It has to go somewhere. And it ends up leaking out of a weak spot. Okay, and they develop a leak. But unless you treat the underlying high pressure, you will not be successful in just treating the leak. It'll open right back up. Patients won't heal properly, and they can get confused and think that this is just repeated leaks when the problem is really the high pressure encouraging those. So Hugely important. So it's easy to miss because oftentimes on MRI, there's little or no things that jump out at you. The signs of high pressure in school, when we go through school, is that we learn to look for more dramatic presentations, like empty sella, where the pituitary gland is basically missing. It's so squished from high intracranial pressure. But in clinic, that's not what we see. We will see partially empty sella, oftentimes. And we have seen empty sella, do not get me wrong. But we have plenty of patients that you look at the MRI and go, yeah, looks okay. Basically, there is nothing there that's going to jump out at us and say that's a high pressure patient. And then we look at the fundus images. And as eye doctors, we're trained to always look at the optic nerve, and we're looking for swelling of the optic nerve or papilledema. When patients don't exhibit full-blown papilledema, we learn as eye doctors to blow right past it. But if you look in the Driscoll theory, you'll see where looking at patients, we saw the optic nerves often looked a little bit swollen. Basically, on one side of the optic nerve was not atypical. And as doctors, we call that a tilted disc, perfectly normal. It's anatomical, the way they were born. But I noticed in our studies that the patients without illness didn't show that. So I have a feeling we're overdiagnosing as eye doctors tilted discs. And instead, we ought to consider the possibility that that could be a subtle sign of high intracranial pressure. A B scan is also one way of measuring the width of the optic nerve sheath that can sometimes tell you if a patient has high intracranial pressure. We will oftentimes ask the radiologist when we request an MRI to measure the optic nerve sheath. We want a slice of that, and we want that measurement. Anything over a half of a centimeter is suspicious for IIH. And then finally, we have absolutely seen patients who don't show much of anything on imaging. The testing is it's okay, but their symptoms are suggestive of it. And in that case, you want to look at a treatment trial. Bring the pressure down. We use acetazolamide to do that. Bring it down and see if some of those symptoms resolve. You nailed it. Okay. And Diamox or acetazolamide can be a good diagnostic test. It is relatively low risk, certainly more than any invasive procedures, right? It's a medication that's been out for forever. We know everything there is to know about Diamox. There will be no surprises. We know certain side effects. We know what to look for, short-term and long-term. And you can't bring your pressure too low with Diamox. I think that's so important for you guys to understand that, say, when we prescribe it as eye doctors for certain forms of glaucoma and eye disease, or to prevent altitude sickness, there is never a concern that it could bring the pressure too low. That is not a thing. There is a feedback loop where if our pressure drops, we make more. Okay, so your pressure can be too high, but it cannot get too low with Diamox. Thus makes it a very low risk treatment trial. Now, one trick to this, though, we learned is that most patients with IH are very sensitive, right? We just become a ball of sensitivity to medicines, chemicals, foods, stress, heat, you name it, we're sensitive. And our reactions sometimes to medications and other things can be dramatic. And we have to know, and one thing I really like to guide patients with is when that reaction is, it's okay. This is going to go away quickly, push right through, you're going to be just fine, versus, oop, game changer, we need to do something different. And so many doctors I see let the patient dictate that, where they'll have something that they consider to be an adverse reaction and stop treatment and leave the patient to suffer. And I think that's horrible. So being able to tell when something is a short-term side effect or the adverse reaction is very brief, it's going to go away, give it 12 hours or whatever, is worth figuring out because we don't have good alternatives to acetazolamide or Diamox. Topamax is insufficient in most patients to hit this properly. The level of medication in there to lower pressure is so small. The carbonic anhydrase inhibitor in that is so small. That's not a great option. Lasix or other medicines to pull fluid out of the body, honestly, they just don't touch it. I've got to tell you, they just don't touch it. And you do not want to have to do something invasive like a brain shunt. Just promise me you won't jump to something invasive like that unless you've fully ruled out the possibility of high pressure. The education we will be providing, we're pulling it together now, can talk you through basically anything you ever wanted to know about this. Okay. I think it's really important to know you've got to take charge as a patient because your doctors probably won't be comfortable with it. They don't really see that many of these patients, and it can be a foreign thought to them. The gold standard, or considered the gold standard in the past to diagnosis, has been a lumbar puncture. You do not want a lumbar puncture, nor is it necessary. When it's invasive, it punctures the dura, the lining around the spinal cord, and that is where we worry it won't heal properly, and you could be left with a continuous slow leak, and that can be disabling. So you don't need the proof of a lumbar puncture. A lumbar puncture could miss high intracranial pressure if it waxes and wanes. Okay. If it's positional, if it bothers you more when your inflammation's up for women, if the time of a cycle is bad and your pressure goes up, if the barometric pressure changes, what have you, a lumbar puncture could miss it. But more importantly, and really why doctors are walking away more from lumbar punctures to diagnosis, is the risk of spinal leaks and induced Chiari. Induced Chiari is where the back part of the brain gets pulled into the spinal cord area. It just sucks right down. You do a tap on the bottom of the spine, the fluid exits, and that lower brain, hindbrain, can just pull right down. It acts like a cork. It just, and then the pressure builds horribly on the brain, but they can't measure it. In fact, I often hear doctors say, well, the fluid just squirted right out and then it just stopped. There's nothing. How can a patient have no cerebrospinal fluid? It's like, oh, they got it. It's all on the brain and it's corked right at that Chiari, and that can be a real problem. So fortunately, with professionals, I see that they are getting away from lumbar punctures, but as a patient, you've got to look out for yourself. Okay. You've got to take charge of this. To some degree, and make sure that your interests are protected, that the least invasive approach is best. Finally, I wanted to close with, are there any problems with just letting the pressure go? What if your pressure's high and you decide, I'm just not going to do anything. Let me just try to ride this out. A lot of us do, at least until it's diagnosed. There is a fair amount of research out there showing the risk of many neurodegenerative conditions goes up when we have high intracranial pressure. One thing we did back in our studies was reach to people whose head circumferences grew too fast when they were young, suggesting, but not proving, that they had high intracranial pressure from a young age, and finding out what happened to them as they got older. And we saw epilepsy, narcolepsy, cataplexy, every lepsy known to man, lots of neurodegenerative conditions, and a propensity for POTS. As a patient, what happened to me in treating this was a surprise because, one, getting the pressure down, I felt so much more functional. I was less miserable. Okay, well, great. We'll take that sometime. But something my neurologist and I worked out was when I thought the pressure was basically maintained, it felt pretty good to me. But every once in a while, I would have a symptom. Like sometimes I'd be driving and then I just get like a split second. I felt like there was a little vertigo. Or I'd be focusing on something, reading something, and suddenly I had trouble focusing with my eyes. Again, just for a split second. But I knew that was likely a little bit of high pressure. And I asked him, what do you think? I can blow right past this. Okay, it's not causing POTS again. It's not making me feel sick. And I don't know that I need medicine for it. And he said, well, tell you what, why don't we stay on some treatment just at nighttime? Okay, and keep that pressure away. He said, I think of it like a migraine patient, where if I give them medicine for the migraines, they feel better. That's great. But if I can give them medicine to help prevent migraines, they're healthier, happier, their relationships are better, they make better grades, they make more money, whatever. Everything in life is better. Okay, so I did that. I was not anticipating that. I had moved past POTS. I was working full time, more than full time. But I was resting on the weekends because I thought most people did that. At the end of a long day, I would rest, right? Seems normal. No, that started to go away. And I remember coming home after a long 10-hour day or something saying, so what are we doing tonight? And then on the weekend, getting up and saying, so what are we planning this weekend? And I thought, that's a change. My functionality continued to improve over even 2 years. And I wasn't expecting that. So it's another reason I really just continue to keep waving this flag. Let's not miss this. Okay. And if you suspect you have high pressure, please consider the possibility. Imaging is important, testing is important, but it can still miss it. So consider a treatment trial or finding someone to help you through this. It's something we do at POTS Care, but let us know if you need help. But I'm hoping everything's in the book that you may possibly want or need. If you have any questions, please feel free to chat them. But a couple of people did ask me in advance of this live stream if I could recommend anything non-medical for this. And absolutely. In fact, we'll have a whole class on this of lifestyle changes, diet you want to be careful of. Some medicines can increase intracranial pressure. But I will tell you, as a patient, those are usually insufficient to get you on top of it. It can help prevent exacerbations. It can help you push through some rough times. Things like high salt. Don't do high salt. Salt is one of the worst things you can do if you have high intracranial pressure. And yes, I realize it is still the go-to treatment for POTS. I am as horrified as you are. Avoid tyramine foods if your pressure's high. Tyramine foods are like sausages, cheeses, dried meats, that sort of thing. Be real careful of your neck area. We don't recommend chiropractic adjustments on the neck. Too much can happen to that delicate brainstem. Light massage is okay, but certainly no head-on sports, anything that you could mess you up there. And even neck exercises. This is something a lot of people who think they may have craniocervical instability will try to do. I know I did. No, just made things worse. Okay. So we'll cover a great deal, some education there, but honestly, it won't replace what medicine can do. Okay. And do know that more and more is coming out about this. Finally, the research centers are starting to catch on. It has been such a long journey, almost 15 years of explaining this to people, jumping up and down, trying to help people. Finally, I heard a talk from one of the researchers at Mayo that said, we're starting to consider the possibility of IIH in these conditions. Wonderful. And then they said, and we may have gotten it wrong where most of these may not be leaks. They may present the same way. And I think that's huge forward progress. We saw a patient not that long ago at Potscare who was treated for a leak, and they never considered high pressure. It was high pressure, it wasn't a leak. So I'm so happy to see that that's where it's headed. What wasn't exciting was to hear the closing of, so we are trying to figure out how to even create studies for this. Right. If you're a patient suffering today, as I was suffering 15, 20 years ago, I couldn't wait for those studies. And I thought, if there is a low-risk medication out there to help me, why can't we just jump right to that and do what's called retrospective analyses, where we can then talk about what happened? We absolutely can do that. So respect the scientific process, but please don't feel like you have to wait for every publication out there and every research center to agree that this is a problem. IIH is a problem in this condition. Thank you. I am so happy you guys joined us. And I wanted to thank you because your support for the POTS Rebels means so much to me. It is hard to go against everybody out there and to just stick our necks out and expose any sort of self-esteem I have to experts trying to shut us down. We know what we're doing. We got this. We know how you can identify the causes of POTS and beat it. We're going to be explaining that and talking you through it. So thank you for your support. And we'll continue doing these live streams. I also am going to add a Google Meet soon where we can actually talk back and forth. So I'm looking forward to that. Stay tuned. I'll see you on Patreon Rebels. Thank you.